Welcome to the deep dive. Today, we are strapping in for a fascinating discussion about medical research that isn't just, small steps forward. It's about an active revolution.
It really is.
We're diving into the management of atrial fibrillation, or AF, a condition that affects millions of people. And for 2 decades, the treatment strategies have been remarkably consistent, almost immovable.
Well, that's the core of this deep dive, isn't it? When you have 20 years of established medical consensus built on these huge influential trials, and then a new trial comes along and fundamentally throws the textbook out the window.
You have to pay attention.
You have to stop and pay attention. We are witnessing a complete reassessment of how AF is treated.
So our mission today is to unpack the results of the groundbreaking EAST-AFNET 4 trial, which is really driving this huge shift. But before we get to the new data, let's nail down the old battle lines. What are the 2 core strategies for managing AF?
The choice is, well, it's deceptively simple on the surface. When a patient comes in with that irregular, often rapid heart rhythm from AF, the clinician faces a fork in the road.
Yeah.
Option 1 is rate control. You basically accept the abnormal rhythm, but you give the patient medication to just slow the heart down, get it to a safer, more manageable pace.
So you're accepting the irregularity, but controlling the speed.
Exactly. And option 2, rhythm control, is the more aggressive approach. You're actively trying to reset the heart into a normal, regular rhythm, what we call sinus rhythm, and then keep it there long term.
And for a whole generation of cardiologists, the guidance, especially for patients with persistent AF who weren't, crippled by symptoms, it leaned heavily toward rate control. Why was that?
It wasn't arbitrary. It was all data-driven. The entire paradigm was built on the legacy of the AFFIRM trial.
Right.
The atrial fibrillation follow-up investigation of rhythm management. It finished up around the turn of the century, randomized over 4,000 patients. And its key finding was that there was no significant difference in overall mortality between the 2 strategies.
That's a really powerful statement. If the complicated, risky rhythm control strategy didn't actually save more lives, why do it?
Precisely. Why put the patient through it? That was the ghost that haunted cardiology for 20 years. If rate control worked just as well for survival, it was simpler, it was safer. And this wasn't just one trial. It was backed up by others like RACI, STAFF, and AFCHF.
The consensus was settled.
It was settled. If you're older, less symptomatic, we'll leave your rhythm alone and just manage the rate.
Okay, so let's unpack this. That 20-year stability has now been completely shattered by this massive new study, the EAST-AFNET 4 study. What was the crucial difference here? What did they do that set this up to succeed where AFFIRM, didn't find a benefit?
The absolute game changer was timing.
Timing.
EAST-AFNET 4 focused exclusively on early rhythm control. They enrolled patients whose AF was diagnosed within the last 12 months. This is so different from the older trials, where many people had had AF for years. Their disease was much more entrenched and harder to reverse.
And what about the people in the trial? Was this a select group of young, healthy patients?
Not at all. This was a real-world, high-risk group. We're talking 2,789 patients, average age of 70 years, 46% were female, and they had a significant burden of risk factors. An average CHA2-IS2 VASC score of 3.4.
And a score of 3.4 means these are not low-risk patients by any means.
No. And that average age of 70 is so critical because that's the exact group that was traditionally managed with rate control.
Exactly.
And look at how they presented. You had first episodes, paroxysmal, persistent. But here's the most provocative part. Almost 30% of these patients were completely asymptomatic at the start.
Wow.
These are the very patients for whom AFFIRM basically said, leave them alone. And EAST-AFNET 4 is saying, no, you have to intervene.
So how did they do it? What did rhythm control look like in this modern era?
It was aggressive and it was modern. The rhythm control arm used antiarrhythmic drugs, sure, like flecainide or amiodarone, but, and this is crucial, it integrated procedural therapy. A full 19% of patients in this group got a catheter ablation by the 2-year mark.
And they were watched closely, right?
Very closely. They had to transmit a single lead ECG twice a week. The researchers were serious about making sure rhythm control was actually being achieved.
And that aggressive approach paid off. The trial was stopped early for efficacy after about 5 years. That's rare, and it always signals a major finding.
It does. And here's where it gets really interesting. The trial's main finding was a profound, significant reduction in the first primary outcome for the early rhythm control group.
Okay, so let's define that outcome again, because this is the core of the argument.
It's a composite of the worst things that can happen to a patient with AF. We're talking death from cardiovascular causes, a stroke ischemic or hemorrhagic, or being hospitalized for heart failure or a heart attack.
And the data, what did it show?
The composite outcome happened in 249 patients in the rhythm control group versus 316 in the usual care group. That gives you a hazard ratio of 0.79.
So a 21% reduction in the risk of these major life-altering events.
Yes. And when you drill down into the components, the benefit was really on the most serious outcomes. A significant reduction in death from cardiovascular causes and an even sharper reduction in stroke.
A hazard ratio of 0.65 for stroke.
It's proof that early rhythm control isn't just about symptoms, it's about fundamentally protecting the organs.
Let's try to translate that for everyone listening. What does a 21% reduction mean in terms of the number needed to treat, the NNT?
It comes out to an NNT of 18 patients over 5 years.
Okay, break that down.
It means you only need to treat 18 newly diagnosed AF patients with this early rhythm control strategy to prevent one of those major events, a death, a stroke, or a heart failure hospitalization.
That sounds like a really effective intervention, but we have to talk about the friction here. Rhythm control is aggressive. There are drug toxicities, procedural risks. Was there a safety trade-off?
Absolutely, and we have to acknowledge that risk. The study did find a numerical increase in serious adverse events that were directly related to the therapy itself, things like drug toxicity or complications from a procedure.
And what were those numbers?
Those serious adverse events happened in 4.9% of the rhythm control group, compared to just 1.4% in the usual care group over 5 years.
So if we translate that into a number needed to harm, an NNH, what are we looking at?
That gives us an NNH of 28 patients over 5 years to cause one serious adverse event.
Okay, so let's debate this trade-off. An NNT of 18 to prevent a death or a disabling stroke versus an NNH of 28 to cause a serious but often manageable side effect. How do you justify that, especially for that 30% who felt fine to begin with?
That is the critical question, and the answer is in the nature of the events. You're trading the risk of a serious but often reversible side effect for the prevention of irreversible catastrophic events, a disabling stroke or death. The trial shows the protective benefit is substantially greater than the treatment risk, even in those asymptomatic patients.
It's a total shift in the conversation. It's moving from just quality of life to survival and serious risk mitigation. So what happened in the past? If EAST-AFNET 4 found this profound benefit, why did a firm conclude rhythm control was no better 20 years ago?
It really boils down to 3 key differences that basically doomed the older trials to fail.
Let's go through them. You mentioned the first one was timing.
Right, the timing of intervention. A firm enrolled patients who'd had AF for a while. Their hearts, specifically the left atrium, had already undergone significant, often irreversible structural changes. We call it remodeling.
So it was too late, in a sense.
It's much harder to fix. EAST-AFNET 4 intervened early, catching the disease before it got entrenched. It maximized the potential to maintain that normal rhythm and prevent the harmful remodeling.
That makes perfect sense. What was the second difference?
The use of modern therapies. Back when a firm was running, rhythm control meant older, more toxic drugs, mostly amiodarone and sotalol.
And those have well-known side effects.
Serious side effects. The toxicity of the drugs themselves likely canceled out any survival benefit from being in sinus rhythm. EAST-AFNET 4 had safer drugs, and critically, it had catheter ablation, a targeted, non-drug approach used in almost 20% of their patients.
So the old rhythm control was a double-edged sword. You fix the rhythm, but the drug might cause harm that negates the benefit.
Precisely. And the third difference is maybe the most important lesson we've learned in the last 2 decades, the anticoagulation strategy.
Tell us about that. This was a fatal flaw in the old model.
It really was. In a firm, if a patient got back to a normal sinus rhythm, clinicians were often given the option to stop their blood thinners.
Wow.
The flawed thinking was, no AF, no stroke risk. But we now know for a fact that stroke risk is driven by underlying factors, age, diabetes, heart failure, not just what the rhythm is doing on any given day.
Ah, I see. So they were telling high-risk patients who got back into rhythm, you can stop the blood thinner, which just dramatically increased their stroke risk.
Yes. You were protecting them from one thing, but exposing them to the number one fear, a stroke, by taking away the proven protection.
So it masked any potential benefit of fixing the rhythm.
Completely. EAST-AFNET 4 fixed this. Anticoagulation was mandated in both arms according to guidelines, no matter what the rhythm was. This allowed the true benefit of rhythm control to finally shine through.
This is where it gets so practical for you, the listener. How are guidelines actually changing on the ground now?
Well, the old guidelines made rhythm control feel like a niche option for the young, the very symptomatic. The new conclusion from EAST-AFNET 4 is transformative. Early rhythm control is now strongly supported as a preferred initial strategy for patients with newly diagnosed AF, even if they're older, even if they're asymptomatic.
So we're no longer waiting for symptoms to develop before we act.
We're acting early to prevent those major cardiovascular events down the line.
Okay, but what about patients outside that 12-month window? The person who has had AF for, say, 2 years?
That's a great point. The interpretation is that the strategy is most effective early on. Once you're past that mark, the benefit probably diminishes because of that remodeling we talked about. But expert consensus would still say that for symptomatic patients, these aggressive modern strategies, especially ablation, should still be on the table.
So the default approach has shifted, but clinical judgment is still key.
Of course.
And for a family doctor managing a new AF patient today, what are the immediate practical steps?
The workflow is much clearer now. First, a thorough baseline workup is non-negotiable. ECG, an echo of the heart, labs. Second, you immediately evaluate their stroke risk and you start anticoagulation based on that risk, period. That's stroke prevention, full stop.
Before you even decide on rhythm or rate control.
Absolutely. Then, while you're figuring out the long-term strategy with a specialist, you have to initiate rate control right away if the heart is racing. Use a beta blocker, get the heart rate under 100. This stabilizes the patient and sets the stage for the specialist to come in and pursue rhythm control, knowing they're providing real outcome-based protection.
So, to summarize the shift, the big takeaway is that early, proactive rhythm control isn't just for the highly symptomatic anymore. It offers tangible benefits, fewer strokes, less cardiovascular death for newly diagnosed AF patients across the board. The old paradigm is gone.
It is, and we've seen that modern approaches, especially the early use of catheter ablation, were key to the success of EAST-AFNET 4. And this, it raises an important question for the future, something for you to mull over.
Okay.
Since we now intervene early, and we know anticoagulation must be maintained regardless of rhythm, how will future research quantify the benefit of maintaining sinus rhythm exclusively through non-drug methods, like even earlier, more frequent ablation? If you could avoid the drug-related side effects, that NNH of 28 altogether, how much further could that NNT of 18 drop, and what new trade-offs might emerge then? That balance between drug risk and procedural risk is the space that's going to define the next decade of AF management.